Good morning, everyone. Thank you so much for this kind invitation. I'm going to be talking about the most difficult patients in terms of decision-making and how do we decide to what type of, if you want to use the word aggressive therapy, to give them and how to make these decisions. I should note as an aside that your steps are not geriatric friendly, so you should be aware of that. All oncologists are geriatric oncologists. All surgeons are geriatric surgeons, and I don't mean old surgeons. I mean older patients. Now, why is that? Well, first of all, we have an aging of the population. We know, and as an oncologist, risk of cancer increases with age. Older patients have very specific needs, and we're dealing now in the world with more complex treatment options. We know that cancer incidence and mortality increase with age. And if you look at all major cancer types, they're predominantly in older patients, whether you want to include leukemia, lymphoma, or all the solid tumors. Just to give an example, in colorectal cancer, which we've just been talking about, the median age of colorectal cancer diagnosis in the U.S. is 68. The median age of death is 74. But the MOSAIC trial, which established adjuvant treatment with FOLFOX, the median age was 60 years. And this is very typical for clinical trials in which patients on the clinical trial are 10 to 15 years younger than the patients in the general population. So therefore, we always have to extrapolate data to the older population. 60% of cancers in those greater than 65, and 70% of cancer mortality is in patients over the age of 65. In the world is aging, particularly North America and Western Europe. Just to give you an example, if you look at the median age of the populations in various countries, Israel is kind of young-ish, but not young, getting older, which 11% of the population is over 65. You can see where the U.S. is. And it's very interesting, where a large majority of the geriatric oncology research is being done is in Italy and France, with a very aging population. This aging population puts great stress on medical health care, because as the population ages, the number of people contributing and working into the healthcare system is much less. In the U.S., the population likewise is aging. It's estimated about 20% of the population will be 65 years of age and older in the next 10 years. If you look at this population pyramid, you could see how the U.S. population distribution has changed. On the left, in 1960, there was a very broad base of younger patients, starting to the begin of what we call the baby boomer generation. And right now on the right, you could see a kind of a rectangularization. It's more of a rectangle, and now a bulge is beginning to appear as the older patient population increases. Israel, it's not quite as dramatic, but you can see the change. You could see 50 years ago a much broader base of younger people in Israel. And as you can see, it's kind of almost becoming a triangle right now. Now, we typically think of life expectancy from birth. So, for instance, in the U.S., from 1850 to the present time, the life expectancy is approximately doubled. But life expectancy from birth takes into a number of factors, primarily infant mortality. When we're dealing with older patients, what's much more important to us is what is their life expectancy at that time you're seeing them. If we're contemplating an adjuvant treatment protocol, we have to say to ourselves, will the patient live long enough to benefit from that treatment? Will they tolerate the treatment? And will the patient die with or from cancer or, God forbid, the results of our treatment? So right now, a 75-year-old woman has about a 25% chance of living into her 90s, and half of them will live into their upper 80s. Even those with significant comorbidities will live 5 to 10 years. If you think about the risk of recurrence from colon cancer, which is in the next 2 to 3 years, this data is particularly important. So there's an increasing incidence of cancer with age. Medical problems complicate treatment, such as comorbidities. Older patients do not participate in clinical trials, for the most part. We have ways now of predicting side effects and improve outcomes. And a reminder that cancer survivorship issues is very important in older patients, as the vast majority of cancer survivors are over 65. So we have more older patients living longer, generally living healthier with less comorbidity. We have much more complex and expensive cancer treatments. So we have many more patients needing cancer therapy. Traditionally, how do we know what to treat our patients with is on clinical trials. Clinical trials, for the most part, are excluding patients, whether by intent or just by the nature of the study, older patients. Older patients are not eligible because of comorbidities, heart, kidney disease. Usually in the U.S., they are white. They're usually from cancer centers, very little participation in community settings or rural settings. And there are physician barriers to entering patients on clinical trials, as physicians have been reluctant to enter their patients. If you look at data from the National Cancer Institute of drug therapies and clinical trial participation, there's virtually no data patients over the age of 80. I could extrapolate that a little bit to 75. And this has really not changed very much in the last 20 to 30 years. So while we like to practice evidence-based medicine, if you're treating older patients, which we all are, then there really isn't a lot of evidence-based to treat your patients. You're always extrapolating. So again, what is geriatric oncology? Health status interferes with oncology decision-making. Older patients have decreased reserves, so if you subject them to a stress, surgery, chemotherapy, etc., they are much more difficult for them to bounce back. They have increased comorbidity, and the older patient is this working? Okay. The older patients are much more heterogeneous. There's no one-fits-all approach. So a little bit about geriatrics, so don't get scared. I'll tell you a little about geriatrics. When we evaluate a patient, what we're really looking for is trying ways to define whether the patient fits into these categories. Are they the primary healthy patient who, almost of any age, with exceptions, can withstand standard therapy, whatever we define that to be? Most of the older patients are this intermediate and vulnerable group where they have decreased functional reserve. They have some functional limitations. However, they still have the ability to bounce back. And then there's the frail group in which really we have to think long and hard about whether really to intervene with chemotherapy surgery or whether palliation would just be the best way of taking care of them. Older patients have multiple comorbidities, and many patients have multimorbidities, many medical problems. And again, as I mentioned, it limits their clinical trial participation. The effect of comorbidity on the biology of cancer, which is still really undefined, but there are inferences that it may be true. Many studies are highly selected patients. Older patients are subject to significant toxicities, and these comorbidities compromises the completion of therapy. And if you know in advance the therapy won't be completed, you really have to maybe pick a different course. What's very important in older patients is function. Function predicts survival. The traditional measures of cancer performance status, such as the Karnofsky and the ECOG, are really not adequate and are really very poor predictors in older patients. We need to look at other functional measures, and I've listed a few. The activities of daily living are the very basic functions, like you were treating an infant. Toilet, feeding, dressing, grooming, ambulation, bathing. If a patient can't do this, forget about chemotherapy. I mean, you really have to think long and hard. And people always get scared about geriatric assessment. This takes about 30 seconds. The instrumental activities of daily living, likewise, are very brief but very predictive. And as I'll show you later, even one or two deficiencies in something as simple as this can predict surgical morbidity and mortality. Okay, so if a person can't take care of their home, how does that figure into surgical problems? But believe it or not, it does. And taking medication is particularly important because to take it correctly, older patients are now taking anywhere from 5 to 10 plus different medications, and if they can't get that right, they're in big trouble. Geriatric syndromes are important. And in a surgical group, things like post-op delirium, falls are extremely important as a complication of treatment and to predict poor outcomes. So if you look at mortality, and this is in a community-dwelling older patient population, nothing to do with cancer, you can see how function predicts survival. One of the things we're looking at is the frailty phenotype. And how do we know if someone is frail? It's actually a very big debate in geriatrics. But this is from Linda Fried, who's now at Columbia University. She talked about exhaustion, weight loss, low activity, slow gait speed, and poor grip strength as a definition of frailty. Many of your older patients will tell you they're just tired, they're exhausted. Sometimes people refer to this as sarcopenia. This is a hallmark of frailty. These are the patients who are going to do poorly with quote-unquote standard treatment. So we have to identify the vulnerable or the frail patient. Why is this important? They will not complete therapy. They will have issues about toxicity, social issues. They will have excessive toxicity, as I mentioned. You will maybe make them suffer more, and they will not benefit from treatment. You really have to look for that vulnerable patient, but that patient with the proper support can withstand therapy, and there are many ways to do it, which I don't have the time for. One of the most common standards of frailty is what's called the Balducci criteria, and it's very, very simple. This is not, as we say, rocket science. Anyone over 85, people who are dependent on ADL, like I mentioned, people with multiple comorbidities are one of the geriatric syndromes. So if you have a patient who's had multiple falls, you have to think long and hard about almost any procedure. So if you're frail, you have increased mortality, increased incidence of hospitalization, increased disability, and other problems. There are many, many assessment tools. Again, I'm not going to get into that right now, except to say that these tools are actually very simple to administer. The G8, for instance, which is a very commonly used tool in Europe, is a very simple thing to administer. You don't even, a nurse's aide, or you don't have to even be a medical professional to do these evaluations. Geriatricians do the comprehensive geriatric assessment. Medical oncologists and surgeons will never do a comprehensive geriatric assessment. They shouldn't do it. But what we're going to do is we're going to pick out pieces to make a very brief and accurate, hopefully accurate, predictor of how to treat patients. So can we predict survival, toxicity, and adverse events? Amazingly, one of the best predictors of mortality is how fast a person can walk. This gait speed. This is a study from Stephanie Studensky at the University of Pittsburgh who showed, and this has been validated many times, how gait speed predicts mortality. Okay? And this is in a general elder population, median age 73 and a half. This is an online web-based program called ePrognosis. Very simple to use. It gives you a sense of prognosis, a sense of how long the patient can live. So if you're thinking of a procedure, giving adjuvant chemotherapy, and their mortality from non-cancer causes is very high, you say to yourself, well, hold it, let's reevaluate, let's rethink. And this is used very, very commonly in the geriatric oncology world. This was a surgical series called the PACE score by Ricardo Audicio, looking at these simple measures. I will tell you, instrumental activities of daily living almost always come through as an extraordinarily powerful predictor. Falls. This is from JAMA surgery just from 2 years ago, looking at the incidence of postoperative complications in general surgical setting in patients who've had falls. If you see on the right, if you had greater than 4 falls in the last 6 months, your chance of significant postoperative complications is 100%. I think that's a very good predictor. The time get up and go. How long does that take? 1 minute. The patient gets up, walks 3 meters, and sits down. A very powerful predictor of postoperative morbidity and mortality. Frailty. If you could show the patient, this is in a gynecologic oncology series about 30-day postoperative complications. So if you have a frail patient based on criteria, not just our feelings, then you have to be very cautious. The Cancer and Aging Research Group has been established in the U.S. looking at these predictors. This was a chemotherapy study, 500 consecutive patients over the age of 65 with a 20-minute assessment. I will tell you, the patients could do most of the assessment on their own. You don't have to do that. And if you look at various predictive score, which include the criteria which I've mentioned, age, and very simple things like renal function, anemia, falls, gait speed, IIDLs, if you look at the model, the number of predictive factors increases. You're predicting grade 3 plus toxicity. And very, very importantly, two other takeaways from this is the lowest risk patients still had a 25% incidence of severe toxicity. So those are your vulnerable patients who you still have to be very cautious about. And if you look on the right, Karnofsky, physicians were unable to predict toxicity. So you really need more than our clinical judgment. Clinical judgment could just take us so far. So people around the world, what are we looking at? What are we doing for geriatric oncology research and education? I'm involved in an organization called the International Society of Geriatric Oncology. We have about 1,000 members in 40 countries, and we're trying to raise awareness, physician education, and stimulate research in the treatment of older patients with cancer. So we have three directives: education, clinical practice, and research. And for the sake of time, I'm just going to limit it to tell you about, we've established part of our mission of education, these SIOD clinical guidelines. They've been published in many peer-reviewed journals, such as Annals of Oncology, the Journal of Clinical Oncology, and surgical journals. And we also have our own journal, the Journal of Geriatric Oncology, which is indexed in PubMed, and we encourage, consider submitting papers to our journal. ASCO, the American Society of Clinical Oncology, has really been at the forefront of geriatric oncology education and research. They've recognized the importance of the field. At the meeting that was just completed last week, we had multiple sessions on geriatric oncology, a clinical science symposium, a special interest group, and ASCO's own guidelines. ASCO also, in addition to the Journal of Clinical Oncology, has two publications called ASCO Connection, which in January of this year highlighted geriatric oncology, and the ASCO Post, in which I edit a monthly column on treating older patients with cancer. So you can get that online. ASCO has responded to the Institute of Medicine. The Institute of Medicine this year, in their Delivering High-Quality Cancer Care, charting a new course for a system in crisis, highlighted the needs of older cancer patients. And ASCO formed a special interest group and looked at various problems in treating the older patients with cancer. We need to improve the evidence base from ongoing research. We have to rethink clinical trial design, geriatric assessment, the issue of biology and aging, funding issues. Some people feel the FDA should incentivize drug companies to study chemotherapy in older patients, which they currently do not do. And we need to increase recruitment of patients to clinical trials. ASCO already talked about a workforce shortage, how the demand will outpace the ability to take care of these older patients. In the United States, there are very, very few geriatricians. They're the lowest paid physicians, I think maybe except pediatricians. I mentioned already the Cancer and Aging Research Group. This was originally organized to give junior attendings an opportunity to study geriatric oncology, and we've published papers, and the predictive model that I mentioned is an outgrowth of that organization. And this is the paper I mentioned earlier. The cooperative groups, in the U.S. has been a reshuffling of cooperative groups. So the Alliance also has a geriatric oncology organization, which we're doing another number of database studies. We have an elderly committee, so if you really want to get into this kind of world, I think one of the first good steps is just get a database of the patients that you're seeing now and really think and look hard at the distribution by age and what their outcomes have been and how they've been treated. And the NRG, which is a conglomeration of two cooperative groups, including the Gynecologic Oncology Group, did one of the first prospective clinical trials in ovarian cancer in older women. This was GOG 273, in which patients over the age of 70 received various chemotherapy regimens, and in terms of their surgery, either had primary cytoreduction or neoadjuvant chemotherapy, followed by cytoreductive surgery, and looking at outcomes. So we've looked at some of these issues of surgical oncology in older patients, including peritoneal surgery. The current study, NRG CC002, is really a outgrowth of all the factors I've mentioned, these predictive models, the Cancer and Aging Research Group model, to look whether these preoperative evaluation can predict postoperative complications in older patients undergoing primary cytoreductive surgery. And it's in the GOG, so this includes ovarian, cervical, and endometrial cancer. At Memorial Sloan Kettering, we have a geriatric consultation service. We do preoperative assessments on all patients over the age of 75. We're studying various postoperative complications. We have a nursing education component, and we have our own 65-plus clinical geriatric program, as well as patient education. We're the only division of geriatric medicine at a cancer center in the U.S. In our own pre-surgical assessment series, we looked at patients over the age of 75 that I mentioned and evaluated them looking at issues of 6-month survival, prolonged hospitalization, and whether the patient, the disposition, whether they end up at home, assisted living, or other institutionalizations. We did one study looking at geriatric assessment as a predictor of delirium and other outcomes, and this is primary and surgery. And as you can see, it really came down to 3 very, very simple predictors. Comorbidity, the Charlson Comorbidity Index, very simple to see. IADLs, again, I've mentioned that a number of times, how IADL is highly predictive, and whether the patient fell or had a history of falls. Again, a very simple measure. So these are extraordinarily simple measures to look at. They're not time-consuming, and they could be, again, highly predictive. So again, the aging of the population has resulted in a marked increase in older cancer patients. The specific needs of these patients allows us to provide the ultimate in personalized care. It requires some form of geriatric evaluation which not need to be complex. We don't have to do a comprehensive geriatric assessment. I've never done one. Physician education, however, is the key to improve care, to evaluate your patients individually, and we need an organized effort. What's the mantra of a geriatric oncologist? Treatment decisions should not be made by age alone. Fit older patients can benefit from standard treatment, so don't undertreat an older patient if they're otherwise fit. Undertreatment is a bad thing too. With proper support, standard therapies are tolerable. Avoid undertreatment when therapy can be curative, and avoid toxicity in a palliative setting such as the frail, dependent patient. Society has treated the elderly poorly, even when curative therapy exists. Ageism needs to be overcome. There's ample evidence of less surgery, lower use of chemotherapy, and less chemotherapy, in other words, arbitrary dose reductions when in an inappropriate setting. We need to improve patient assessment, and again, older patients should be treated in an individualized way, and physician education is key to improve management of older patients. Please consider joining and attending SIOG in 2015 in Prague, where we have about 400 to 500 participants, and it's really a very excellent meeting and it allows for a tremendous amount of interaction. Thank you very much.
Any question from the audience?
Is my Hebrew correct? Okay.
Thank you very much for a most interesting talk. I have a question, a very practical, surgical question. One of the reasons for adjuvant or neoadjuvant protocols is to reduce the incidence of recurrent disease within the next couple of 3 or 4 years. We operated upon an 85-year-old gentleman with a right colonic cancer. He underwent
Well, the answer is, I'll give you a definite maybe. If he was very fit, you see, tolerating surgery and giving chemo is obviously two different issues. If he obviously fit for surgery, but remember, chemotherapy now, we're talking about 4 to 6 months of a lot of things to do to somebody. If they were fit by the criteria, I would. Now, we could debate which regimen, 5-FU alone, probably that's what I would do. Capecitabine, maybe. I'm not a great capecitabine fan for many reasons, which we could discuss. So with a T3N1, I probably would, okay? But I would explain to the patient and the family that we may have to stop early for the reasons I mentioned. If they're very, very fit, none of us could predict absolutely. However, if they did not return to their baseline after surgery, let's say they were a community-dwelling elder patient, and they really never quite returned to that baseline, then I probably would not, because I'd be very nervous that they were in that vulnerable, frail period. People always say, oh, they look so great, but, give them a little toxicity, and they age very rapidly. The other thing about surgery, which I didn't mention, just to bring it up, is the concept that I know the surgeons talking about in this world is this prehabilitation issue about patients who are in really bad shape. Can you get their functional status a little bit better prior to surgery? So that's one thing. You had mentioned neoadjuvant. I treat ovarian cancer. So the issue about neoadjuvant is a lot of the patients I see, the surgeons will tell me, just from a imaging perspective, that this patient will not have an optimal cytoreductive procedure, so they want us to give them chemo first in a chemotherapy-sensitive situation to cytoreduce the patient to make them optimally, make the surgery optimal. I think occasionally what that does also is, because many of the ovarian patients, they've been sick for months and months and months. This is not a positive colonoscopy and the patient's been fine. Many of these patients of any age have been sick for months. And since it's a chemosensitive disease, it does allow the patients actually feel better and their functional status improves to go into surgery. The issue about neoadjuvant and ovarian cancer has been up for debate for decades. I think actually one of the papers that was shown, the Vergote paper, kind of said that giving neoadjuvant therapy is not adverse in terms of overall survival. So that's a long answer, but that's, the 85-year-old is a tough one. And I would have to really spend 2 or 3 days thinking about that one, and the patient would have to prove to me, just get the feeling that they could really stand the therapy. It would be a tough call.
Thank you very much, Professor Lichtman.
Okay, thank you.
תודה לכולם.